All right. Well, good afternoon, everybody. I know folks are still joining in, but we do have a lot to talk about, so I'll get us started. Thank you so much for joining us today. My name is Tatiana Shippey, and I am an Associate Director of Research for the Center for Healthy Aging and Innovation. We're pleased to welcome you to this important conversation about the challenges and opportunities to build the nursing home workforce. This conversation is informed by the recent National Academies of Science, Engineering, and Medicine report recommendations on nursing home quality. A little bit of context on how this webinar came to be. As part of our planning for our semi-annual CHAI external speaker series, I solicited input from CHAI members on topics of highest importance to them. The topic of workforce was a front lead, with most members, both those in the research and community partners, endorsing its importance. COVID has clearly illuminated the importance of workforce as a key aspect of long-term care quality, and I believe this conversation is much needed. Hence, thank you all for joining us, and let's delve in. So some logistics. For those of you who are joining us just now, please know that we're asking you to put questions in the Q&A while the speakers present. We will save questions till the end and then make sure that we save enough questions for discussion. This seminar will also be recorded. Our first panel is going to be organized as two 15-minute presentations by Doctors Jasmine Travers and Chris Talley, who both served as co-authors on this NASM report. They will share their national recommendations from the panel as they pertain to the workforce, but also provide personal reflections and context for the recommendations. And so with that, let me introduce Doctors Travers and Mueller. Dr. Jasmine Travers is an assistant professor of nursing at NYU Rory Myers College of Nursing. Her career is dedicated to designing and conducting research to improve health outcomes and reduce health disparities in vulnerable older adult groups, using both quantitative and qualitative approaches. Currently, Dr. Travers is the principal investigator of a Robert Wood Johnson Foundation 4-year Career Development Award and a Paul Beeson Emerging Leader 5-year K76 Award through the National Institute on Aging. Dr. Travers has published widely on the topics of aging, long-term care, health disparities, workforce diversity, vaccinations, and infections. Dr. Travers is a member of the AARP Public Policy Institute Advisory Board and of the National Academies of Science, Engineering, and Medicine Committee on the Quality of Care in Nursing Homes. Second, Dr. Chris Mueller is a professor and a senior executive associate dean of academic programs at the University of Minnesota School of Nursing and holds the Catherine R.C. and R.C. Walton Lilly High Chair in Nursing Leadership. Dr. Mueller's research career has focused on improving the care of older adults living in nursing homes, and her research focuses on factors that can influence quality in nursing home care. She has served as a PI on numerous grants and received over $5 million in federal, national, state, and local funding. She has provided national leadership on teaching geriatric nursing with a particular emphasis on using the nursing home setting as a clinical learning laboratory. She has called attention to the role of professional nursing in nursing homes that are transforming both environmentally and through clinical and organizational practices to support person-directed care. Dr. Mueller is a member of the National Academy of Medicine Committee on Nursing Home Quality and is the chair-elect for the Health Sciences section of the Gerontological Society of America. She serves on the board of directors for the National Hartford Center for Gerontological Excellence. You see, we have highly esteemed speakers on this panel. And so with that, Jasmine and Chris, I will hand it off to you.
Thank you so much for the invitation to be on this webinar and to share aspects of the NASM report related to the nursing home workforce. I'd first like to point out that the report is very comprehensive and it needs to be considered as a whole. So I'd like to provide first some context for the report and set the stage for the specific conclusions and recommendations related to the nursing home workforce. Next slide. So Jasmine Travers and I were selected to be on the committee that led to this report. And she and I will go over the recommendations in the report related to workforce. Next slide. So what's the big deal about this report? Well, the National Academies of Sciences, Engineering, and Medicine, which is NASM, is a private non-governmental institution that provides independent, objective analysis and advice to the nation, and conducts other activities to solve complex problems and inform public policy decisions. And I think you would agree that nursing home quality is a complex problem. So NASM publishes consensus study reports documenting the evidence-based consensus on the study's statement of task by an authoring committee of experts. So the findings, the conclusions, and the recommendations of all NASM reports are used by governmental agencies, foundations, national organizations, and academic organizations to guide and lead to action. So because of the independence of NASM, the evidence-based approach of NASM and the input of multiple experts and the conclusions and the recommendations tend to carry significant authority. And therefore, this report on nursing home quality is intended to be a significant force in moving the needle to achieve the goals set forth in the report. Next slide. Well, there have been 4 previous reports, and at that time, they were referred to as the Institute of Medicine, and now it's NASM. These reports focused on quality and long-term care. The first report was in 1986, and it served to inform the Nursing Home Reform Act that was part of OBRA 87. The second report you see was asked to evaluate the impact of the Nursing Home Reform Act. Third report addressed staffing in hospitals and nursing homes. And the fourth report addressed the workforce in caring for older adults in a variety of settings. So the timing of the convening of the committee for this report was fall 2020. And we all know what was happening at that time. Nursing homes were in a state of enormous crisis with the pandemic. And we also know that the national attention to nursing homes during 2020 and 2021 was quite focused. Every night on the news, you would hear about the pandemic in nursing homes. So Americans became informed about the quality of care in nursing homes through the pandemic. Next slide. So this is a quote from a family member, and it's also something I and others said, which is the pandemic has lifted the veil on what has been an invisible social ill for decades. Next slide. So every committee that NASM has gives a statement of task, and the statement of task for this committee was to examine how our nation delivers, regulates, finances, and measures the quality of nursing home care. That's a big task, let me tell you. And to also delineate a framework and general principles for improving the quality of care in nursing homes, and that we were to consider all of our work in the context of the COVID, not to ignore the COVID-19 pandemic is probably the best way to say it. Next slide. So this is the cover of the report. Right now, you can download the report from, and I have a slide with the website on it a little bit later. You can download the report, you can print it, all 600 pages, and you can also order the actual hard copy, which is not yet ready, but you can pre-order, and when it's printed, it'll get sent to you. So the committee began its work in January 2021 and finished its work in February 2022 and reached the following conclusions. So we'll go to the next slide. So the first conclusion was the way in which the United States finances, delivers, and regulates care in nursing home settings is ineffective, inefficient, fragmented, and unsustainable, and that we need immediate action to initiate fundamental change. Stakeholders need to make clear a shared commitment to the care of nursing home residents, and ensure that quality improvement initiatives are implemented using strategies that do not exacerbate disparities in resource allocation, quality of care, resident outcomes. And one of the things you'll see in this report is threaded through a focus on equity and disparities in regards to care of older adults in nursing homes. Next slide, please. A fifth conclusion was high quality research is needed to advance the quality of care in nursing homes. And throughout the report, there are recommendations of the type of research. The nursing home sector has suffered for many decades from both underinvestment in ensuring the quality of care and lack of accountability for how those resources are allocated. And finally, all relevant federal agencies need to be granted the authority and the resources from the US Congress to implement the recommendations of this report. Some of you might be thinking as you listen to these overarching conclusions is, well, I knew that. I could have come to those same conclusions. And that's kind of how we were as a committee too, like, duh, we know what's going on here. But these conclusions really helped shape how we address the goals and the recommendations. Next slide, please. So the committee was started with formulating their vision for quality nursing home care, which is residents of nursing homes receive care in a safe environment that honors their values and preferences, addresses goals of care and promotes equity, and assesses benefits and risk of care and treatments. Next slide. The committee also developed a framework to guide the work in the context of the vision. The committee concluded, based on the evidence, that the model of quality of care is not the reality in many nursing homes, and that huge gaps in the quality of care remain despite years of research, advocacy, regulations, and all those reports. Next slide. So there's 7 goals that the committee identified, and each goal has associated recommendations. And here's where you can download the report, nationalacademies.org/nursing-homes. And what we're focusing on today is goal 2. So if you can go to the next slide. Goal 2 is the goal that focuses on the workforce to ensure a well-prepared, empowered, and appropriately compensated workforce. And this is the goal that Jasmine and I are going to focus on for today. So if we go to the next slide. So for this goal, the committee identified 5 categories of recommendations that we will share with you. The committee noted there was a need for complete transformation of worker training and social stature, and these changes to the culture of nursing homes needed to be driven by nursing home leaders. And the committee recommends increasing both the numbers and the qualifications of virtually all types of nursing home workers, along with providing the necessary incentives and supports to achieve those changes. Now, the committee was fully aware of the impact of COVID on recruiting and retaining nursing home staff and the current severe staffing shortage. And the committee recognized there could be criticism by recommending increased staffing requirements in the context of a severe staffing shortage and the challenges of recruiting and retaining nursing home staff. Therefore, I want to emphasize again how important it is to consider the full report and all the recommendations. So we can't use the argument of not increasing numbers of nursing home staff because of fill in the blank, because of, we can't hire them, or we can't pay them enough, or the work environment is not satisfying, and you name it, because the evidence is extraordinarily strong that higher numbers of staff, particularly nursing staff, leads to higher quality care. So it's unconscionable to do nothing about staffing in nursing homes. So the focus of the nursing home workforce not only addressed the need for more staff, but also address their education, training, turnover rates, necessary competencies, challenges with recruitment and retention, and the connection to quality care. Next slide. So the first recommendation is that federal and state governments, together with nursing homes, should ensure competitive wages and benefits to include health insurance, childcare, and sick pay. to recruit and retain all types of full and part-time nursing home staff. And then it goes on to address some mechanisms that could be used to for this recommendation. So the recommendation acknowledges that nursing home staff wages and benefits are significantly less than in some other healthcare sectors, as well as service sectors. Recruitment of workers to nursing homes is close to impossible without competitive wages and benefits, and this has to be addressed. And there are state initiatives, as I speak, attempting to address the compensation of nursing home workers. For example, in Minnesota, there's a bill that includes language to provide workforce grants to long-term care providers for retention and recruitment activities, including bonuses. And it's right, last I looked, it was 118 million. And there's other states that also are doing some other things. Okay, just want to be sure I'm on the right slide. Okay, so the next recommendation is that the Centers for Medicare and Medicaid Services should enhance the current minimum staffing requirements, thank you, for every nursing home. So minimum nurse staffing recommendations were developed by CMS in 2001. That's 21 years ago. And those recommendations went nowhere. Yet today, we still have a vague nursing staffing requirement that nursing homes must provide, quote, sufficient nursing staff to attain or maintain the highest practicable well-being of each resident, unquote. So those 4 reports I showed you earlier have called, for example, 24-hour nurse RN coverage, yet the federal requirement remains at 8 hours RN staffing 7 days a week. So to that end, the committee recommended on-site direct care registered nurse coverage in addition to the director of nursing at a minimum of a 24-hour, 7 days a week basis with additional RN coverage that reflects resident census, acuity, case mix, and the professional nursing needs for residents as determined by their assessments and care plans. So the committee also recognized staffing deficits for other key personnel in nursing homes, specifically the social worker and infection prevention and control specialists. So next slide. And so there's recommendations specific to that every nursing home should have a full-time social worker and that every nursing home should have an infection prevention and control specialist, and went on for both of these recommendations, went on to specify the qualifications that these 2 individuals should have. As previously noted, the last time a significant research on minimum nurse staffing standards was completed was in 2001. They also acknowledged that the type of residents and complexity of needs for residents has changed dramatically since 2001. And further, the current federal nursing home regulations have been in place for over 30 years with some revisions. So the committee then recommended, next slide, that U.S. Department of Health, and those are some of the organizations that could do this work, should fund research to identify and rigorously test specific minimum and optimum staffing standards for direct care staff, and expanding it to advanced practice registered nurses, RNs, LPNs, CNAs, therapists, rec staff, social workers, and others. It should look at weekend and holiday staffing. It should be based on case mix and the type of staff needed to address the care needs of specific populations. And so based on the results of the research, then CMS and state government should update the regulatory requirements for staffing standards in nursing homes to reflect new minimum requirements and account for case mix. I just want to parenthetically add that, you probably get the same emails I do from CMS and from McKnight's and so forth. it's been quite interesting to me, and I'm sure to others on the committee, that we're beginning to see some action already in regards to these recommendations. And for this particular recommendation, CMS is planning to do a study on staffing in nursing homes. Next slide. So the committee also recognized that just having an adequate number of staff is not the whole solution. In order to provide comprehensive person-centered care, staff need to have the expertise to that end. And many nursing homes don't have the expertise to achieve the goals. So the committee drew on evidence of successful models to provide such expertise and proposed recommendations to some of the barriers for obtaining the expertise. So this recommendation is that nursing home administrators, in consultation with their clinical staff, should establish consulting or employment relationships with persons such as licensed clinical social workers, APRNs, clinical psychologists, psychiatrists, pharmacists, and others for clinical consultation, staff training, and improvement of care systems. And CMS should create incentives for nursing homes to hire qualified clinical social workers, as well as APRNs for clinical care, including, and this is a barrier, allowing Medicare billing and reimbursement for these services. So I think that is where I'll hand it off now to Jasmine.
Thanks, Chris. I appreciate that. So now I'm going to go through the last recommendations of this second goal pertaining to the workforce. And I love all the recommendations, but this one's focused on certified nursing assistants really resonate with me in the work that I do. So recommendation 2E is to advance the role of and empower the certified nursing assistant. So the demand for CNAs is increasing, yet nursing homes have persistent challenges in recruiting and retaining workers. The top reasons for CNAs leaving their jobs include a lack of respect and appreciation by leadership, inadequate salary and benefits, a lack of teamwork and communication among the staff, and poor relationships with supervisors, residents, and families. Because of the crucial role of this position in nursing homes, the committee concluded that significantly improving the quality of care for nursing home residents requires investing in quality jobs for certified nursing assistants and enabling more workers to enter the certified nursing assistant pipeline. Therefore, in addition to the recommendations for ensuring competitive wages and benefits, which was presented earlier, the committee recommends that nursing homes provide career advancement opportunities and peer mentoring. So what does it look like for a CNA to advance to an LPN, for example, or advance to a registered nurse? Federal and state governments, together with nursing homes, should enable free entry-level training and continuing education, such as in community colleges, to remove barriers into coming into the CNA workforce. Nursing homes should cover CNA's time for completing education and training programs, again, to remove barriers to being able to participate in these activities. And the Health Resources and Service Administration should fund training grants to advance and expand the role of the CNA, recognizing the contributions that they make to the resident care, and also develop new models of care of delivery that take advantage of the role of the CNA as a member of the interdisciplinary care team. So this is something that CMS, Centers for Medicare and Medicaid Services, has required for CNAs to be a part of these care teams, be active participants. So participating in the care plans, providing information to the team about the preferences and needs and goals of the resident, but it has been a challenge because of different barriers. So really understanding what are the best models of care to make sure that CNAs are included as members of the interdisciplinary care teams. Next slide, please. So recommendation 2F, the Centers for Medicare and Medicaid Services should establish minimum education and national competency requirements for nursing home staff. So in addition to improving wages and strengthening staffing standards, the education and training of the entire nursing home workforce is key to improving the quality of care in nursing homes. So that's one thing when Chris brought up earlier, that all of these recommendations across the report should be taken together, but just even thinking about the education of the workforce and how important that education is going to be to making sure that these recommendations are really adopted as they need to be. So education and training requirements for a variety of nursing home staff are inadequate or non-existent. The committee concluded that the minimum education and competency requirements need to be enhanced or established for a variety of nursing home workers and to be made standard at the national level. So we do see, various education and training requirements varying by state, but recognizing that we need to have minimum standards by the national level. So this leads us to the recommendations specific to this overall recommendation, which first, the nursing home administrator having a minimum of a bachelor's degree and training in topics relevant to their role. So understanding culture change, how is culture change going to happen if that's not a part of the training of the nursing home administrator, and thinking about those who are actually setting the tone, leadership and team building, that being important. So, increasing wages and such is important to the nursing home workforce, but then also, again, what we said was that just appreciation and supportiveness from the nursing home administrators and other leaders is important. Administration and financial management are other relevant topics that are important. Then next, with the medical director, having them complete education or certification programs specific to the care of older adults and certification in infection control and prevention. And then the director of nursing, minimum of a bachelor's degree in nursing with a preference for master's level training, and ensuring that this training includes geriatrics and long-term care, as well as certification in infection control and prevention, similar to the medical director. Next slide, please. Additionally, director of social services, so those social workers, for example, minimum of a bachelor's degree in social work from a program accredited by the Council on Social Work Education, with a preference for master's level training from a program accredited by the Council on Social Work Education. And for certified nursing assistants, an increase in the federal minimum of training hours to become a certified nursing assistant from 75 hours to 120 hours. And this has been, recommended previously, but it has not been something that's been required on the national level. So we are emphasizing this recommendation. And then also considering training that content within this training that includes competency-based training requirements. So thinking about, again, infection prevention and control, care of older adults or those living with dementia, making sure that this is included in that training. Next slide, please. So recommendation 2G, to enhance the education and training of the entire nursing home workforce. The committee concluded that efforts are needed to augment the education, training, and competency of the nursing home workforce on an ongoing basis, so not just one time. Many nursing home workers have no requirements for continuing education related to national competencies, and when such requirements exist, they generally vary by state again. In addition, nursing home residents are becoming increasingly diverse in terms of racial and ethnic groups, LGBTQ+ populations, and younger populations. Yet little is known about their specific care needs in the nursing home setting or their preferences for who cares for them. As a result, the committee concluded that all nursing home workers would benefit from specific workforce-related education and training in principles of diversity, equity, and inclusion, as well as cultural sensitivity and humility with respect to institutional factors such as biases, hiring, pay, and promotion practices, for example, cultural factors such as discrimination, microaggressions, and interpersonal factors such as racial biases. Finally, the committee recognizes that family caregivers, so really emphasizing the important role that family caregivers play in the care of residents, are an essential and valued part of the nursing home workforce and often do not receive the support and training they need to be effective members of the care team, which leads us to this recommendation 2G. The Centers for Medication and Medicaid Services should require all levels of nursing home staff to complete annual continuing education training to ensure that staff members are meeting national competency standards. And remember, earlier on, we talked about providing that free of charge. Next slide, please. And then additionally, nursing homes should provide ongoing diversity and inclusion training, example, self-awareness and approaches to addressing racism, which is a problem within the nursing home setting, often experienced by certified nursing assistants and other workers in that setting. But having this training for all workers in leadership and ensure that the training is designed to meet the unique demographic, cultural, linguistic, and transportation needs of the community in which the nursing home is situated and the community of workers within the nursing home. Nursing homes should provide family caregivers with resources, training, and opportunities to participate as part of the caregiving team in the manner and to the extent that the residents desire their chosen family members to be involved. Next slide, please. Recommendation 2H. As a part of a routine such as at least annual data collection, nursing homes should collect and report data to the Centers for Medicare and Medicaid Services. So in addition to enhanced requirements for key leaders and workers in nursing homes, there is a need to increase the overall numbers of more highly trained professionals, such as physicians, advanced practice registered nurses, and physician assistants involved in the delivery of care in nursing homes. However, the committee found that little is known about the prevalence of these workers. The committee particularly noted a dearth of information about the roles, staffing patterns, and training of medical directors, social workers, physicians, advanced practice registered nurses, and physician assistants. Additionally, few data exists for the numbers and staffing patterns for contract and agency staff providing care in nursing homes. Furthermore, while evidence exists on the association between advanced practice registered nurses and the quality of care in nursing homes, where we see a positive association, baseline data are needed for a variety of professionals to more fully assess their impact on the quality of care for nursing home residents, and ultimately to determine their minimum and optimum staffing levels, as well as innovative staff models to provide high quality care for nursing home residents. Therefore, the committee recommends data collection of baseline demographic information on medical directors, administrators, and directors of nursing, including name, licensure, contact information, and tenure in their position, the geriatrics or long-term care training, expertise, and staffing patterns, including time providing direct care, medical directors, advanced practice registered nurses, social workers, physicians, and physician assistants who provide services in nursing homes, and then numbers and staffing patterns, including time providing direct care for all contract and agency staff providing services in nursing homes. So really understanding who these other nursing home workers are and how much are they providing care to residents. Next slide, please. And the final recommendation, recommendation 2I. So while many of the barriers to recruitment and retention are known, the committee concluded that more research is needed on persistent systemic barriers, including the influence of systemic and structural racism that has created and sustained racial and ethnic disparities among nursing home workers. Therefore, the committee recommends that the U.S. Department of Health and Human Services, such as Centers for Medicare and Medicaid Services, the Agency for Healthcare Research and Quality, and the National Institutes of Health, fund research on systemic barriers and opportunities to improve the recruitment, training, and advancement of all nursing home workers, with a particular focus on certified nursing assistants. So what are the barriers to recruiting these folks and retaining them? This research should include the collection of gender, ethnicity, and race-related outcomes of job quality indicators, such as hiring, turnover, job satisfaction. And we know turnover is now an indicator on nursing home compare. And with that, I will conclude my remarks and turn it over to Dr. Nkimbang, who will moderate our panel.
Thank you so much, Jasmine. And this gives me an opportunity to introduce Dr. Nkimbang as the moderator for the upcoming panel. Dr. Nkimbang is an assistant professor at the University of Minnesota School of Public Health. Her research interests center around understanding the causes of health inequities in minorities and improving health outcomes for older adults. Encompassing her research and policy expertise, she works to develop and test interventions that can be translated into health policies and clinical practice to improve health and eliminate health inequities for minoritized older adults. Dr. Kimbing will introduce our three other panelists who will each take about 10 minutes to respond to these committee recommendations shared by Drs. Mueller and Jasmine. So Manka, handing it off to you.
Thank you so much, Dr. Shippy, for the introduction. Hello, everyone. I'm happy to be joining you all today for this very important conversation. So I'm going to introduce our esteemed second panel. What I'll do is I'll introduce each panelist, and then they'll have 10 minutes to offer their remarks. So we'll start with Dr. Kezia Scales. So Dr. Scales is the Director of Policy Research for PHI, a national nonprofit committed to promoting quality direct care jobs as the foundation for quality long-term care. In our role at PHI, Kezia leads the organization's efforts to strengthen the evidence base for investing in and elevating the direct care workforce that provides essential support for older adults and people with disabilities across settings. For more than a decade, Kezia has studied and advocated for patient-centered, high-quality long-term care with a focus on direct care workers. She has been published in a range of academic journals, including the Gerontologist, Public Policy and Aging Report, Journal of Applied Gerontology, and Sociology of Health and ENOS. She also has disseminated her research findings, policy recommendations, and best practices nationally and internationally through conferences, webinars, media outlets, and more. Kezia holds a PhD in sociology from University of Nottingham and an MSc in comparative social policy from Oxford University in England and a BA in sociology from Queen's University in Canada.
Great, thank you so much. Thank you for that introduction, and thank you for the opportunity to join the webinar today. To celebrate, to my mind, what is a really historic moment with the release of these comprehensive recommendations. And I feel like as I've been sitting here listening to Dr. Mueller and Dr. Travers talk, I've been sitting on my hands because I keep wanting to clap, to applaud, because there's so much important content here that a lot of us have been thinking about and working toward for a long time. So it just feels like a really exciting moment, and I'm delighted to be part of this conversation. I'm going to take my few moments, to talk about why these recommendations matter for nursing assistants in nursing homes specifically, for nursing assistants themselves, and for supporting their critical role in delivering high quality person-centered care to nursing home residents. And that's really what our mission and our mantra is at PHI, that quality care is indivisible from quality jobs. We must address both simultaneously and in tandem to reach the vision of nursing home care that we want to see. So next slide, please. So to just take a moment to provide a snapshot of the nursing assistant workforce in nursing homes. A lot of this background content is in the report itself, but if you haven't had a chance yet to read all 577 pages, I'm just giving it to you here in a nutshell. So nursing assistants, there's about 527,500 nursing assistants working in nursing homes nationwide. The report estimates that nursing assistants comprise about 41% of the nursing home workforce overall. So about 2 in 5 nursing home workers are nursing assistants. But nursing assistants are just one segment as well of a much larger direct care workforce, 4.6 million personal care aides, home health aides, and nursing assistants who work across all care settings in the long-term services and supports continuum and in other settings of care as well. And I do think it's really important to think about nursing assistants in the context of this broader direct care workforce when we're thinking about how to improve recruitment and retention and grow and stabilize this workforce, and so that we can be sure that we're able to deliver the right care at the right time in the right place for every person that requires it. So I'm going to be coming back to that theme a couple of times in my comments. about the sort of bigger context that this nursing assistant, nursing home challenge is embedded in. Nursing assistants provide the majority of direct care for nursing assistants, for nursing home residents. It's estimated that they provide an average of 2.1 hours per resident day of care, compared to about 1.2 hours of care that's provided by RNs and LPNs, licensed practical nurses combined. This work, nursing assistants' role, is physically, emotionally, mentally demanding work. Just one way of illustrating that is that on average, nursing assistants support 13 residents per shift, but at least 1 in 10 nursing assistants support 17 or more residents per shift. This is very, very difficult work. Another way to describe the nursing assistant workforce is in terms of the demographic profile of nursing assistants. This is a workforce that is predominantly female at 91%, majority people of color at 58%, and a significant segment of the workforce were born outside of the United States. 21% are immigrants in the workforce. It's absolutely critical to keep this demographic profile in mind, this understanding of who direct care workers are, who nursing assistants are, because that is tied to how these jobs have been historically and persistently structured and valued or inadequately valued, and also has bearing on how we think about recruiting new workers into the workforce and supporting existing workers as well. Next slide, please. I just wanted to turn quickly to a quote from a nursing assistant who is participating in PHI's Direct Care Worker Story Project, which is a project that aims to elevate the voices and experiences and stories of direct care workers across settings and across the country. And this is Kulix, who works within a continuing care retirement community that includes skilled nursing in Georgia. And it's just a quote from Kulix describing her role. She says, "You have a lot of responsibility taking care of members or residents. You're giving medication, you're doing laundry, you're feeding them, you're giving them a shower, you're making sure they don't fall. You are also taking care of their family members and answering all their questions about their loved ones. We are the eyes and ears for these members, and we know what is going on with them 24/7 more than anybody else." Now, for anybody who has worked in a nursing home, visited a nursing home, spent time with nursing assistants or in a nursing home, this will sound very familiar. This way of describing the nursing assistant role we hear often, and it's really important because Kulix really clearly captures here the unique role and contribution of nursing assistants in delivering care and serving as a link between residents and family members in the nursing home and the broader interdisciplinary team. Next slide, please. And now we've already spoken to this, but the nursing assistant workforce in nursing homes faces long-standing job quality challenges that absolutely predate the pandemic, but that were acutely exacerbated within the last couple of years. Those workforce challenges begin with low wages, limited benefits, and as a result, high rates of poverty and public assistance use among nursing assistants. So what you can see on the slide here is that the median hourly wage for nursing assistants in nursing homes in 2020 was just about $14.50 an hour. That translates into median annual earnings of just about $24,000 a year. These wages and annual earnings are barely competitive against other, quote, entry-level positions that are competing for workers now more than ever, including cashiers, retail food service workers, et cetera. Nursing assistants in nursing homes also traditionally have limited training, entry-level training, as we have already heard, but also few career pathways. So there is the opportunity to move into an LPN, RN, other clinical roles, but that's a large step up the career ladder. And it's not necessarily what nursing assistants are looking for when they are thriving in the frontline direct care role. So there are not very many opportunities for more experienced nursing assistants to accrue additional training, to take on an elevated title, and to raise their wages accordingly. Medication aid is one exception to the lack of career pathways within direct care, but that varies by state. The other exception is the universal worker role that we are seeing in the small home model, but again, not a very scaled up set of opportunities yet. Nursing assistants and other direct care workers, because of low wages, are 35% more likely to hold second jobs, or second or third or more jobs, than the average US worker. And nursing assistants in nursing homes are also 3 times more at risk of occupational injuries on the job because of the physically intense nature of this work. Other longstanding workforce challenges include inadequate support and supervision on the job, and again, limited meaningful integration into the interdisciplinary care team. All of these workforce challenges, again, that were acutely exacerbated during the pandemic, lead to high rates of turnover in the workforce, but also burnout on the job. And yet this workforce is growing, and overall the full direct care workforce is expected to add 1.3 million jobs, new jobs, within a decade from 2019 to 2029 to meet growing demand. That's more new jobs altogether than any other occupation in the country. Most of that new job growth will be in home and community-based settings. But again, we really need to address job quality overall and recruitment and retention overall to strengthen the continuum, the full continuum of care. Next slide, please. So the primary way that we get to better recruitment and retention is by creating better jobs for nursing assistants and other direct care workers. So at PHI, we talk about the 5 pillars of job quality for direct care workers. These include fair compensation, absolutely, living competitive wages and benefits, but also quality training, quality supervision and support, respect and recognition for the unique direct care role and contribution, and real opportunities to progress in direct care roles and beyond. And what's so exciting is that so many of these job quality elements are absolutely reflected in the NASM report and recommendations. So to briefly reflect on the recommendations that impact the nursing assistant workforce, on the next slide, please. These are a few of my reflections and on the recommendations and how important they are. First of all, it's absolutely gratifying and important to see such a clear and explicit emphasis on improving job quality for CNAs and other nursing home staff. So there are recommendations related to competitive compensation, minimum staffing standards to alleviate untenable workloads and enable CNAs to provide the quality of care that they want and need to, but also training and career advancement opportunities and more. So that's really, really important. Also important is the emphasis on data collection, so better understanding what's happening in nursing homes, including with regards to staffing. And what I really want to highlight there is the emphasis on the need for disaggregated data on workforce outcomes. Dr. Travers spoke about this, to look at hiring rates, turnover rates, job satisfaction by gender, by race and ethnicity, and by other characteristics. We really need this data to bring to light and begin to address the structural inequities that define the lives and jobs of nursing assistants and the residents that they support. I also want to uplift that workforce considerations are threaded throughout all 7 goals. So there is goal 2 is entirely focused on the workforce, but all of the other goals have workforce elements or workforce implications to a greater or lesser extent. So the first goal, absolutely, the emphasis on person-centered care, new models of care, emergency preparedness, and other components of that goal, all of those elements rely on strong, stable, competent, supported workers in the nursing home. but also the goal about transparency and accountability. That includes transparency and accountability around staffing patterns, ratios, and so forth. Financing and payment reform, which is another set of a goal and set of recommendations, is absolutely critical for a range of reasons, but including for reimagining nursing assistants' wages and benefits and job quality overall. And as another example, the emphasis on quality measurement and reporting, staffing measures, again, are front and central to that goal as well. And then finally, I would just really reemphasize a point that Dr. Mueller and Dr. Travers both made, which is the need for coordinated action across these goals. They are so interdependent in terms of actually seeing transformative change. So really, we absolutely need to think about a coherent way forward that takes into account all of those goals and recommendations. And finally, in my last minute, I would just add a couple of thoughts about how to build on or around the recommendations. There's so much there already that I hesitate to do this a little bit, but I just wanted to bring in a couple of other thoughts about what we need going forward. One point that I'd like to make relates back to the argument that I made that nursing assistants are part of this larger direct care workforce. And what I would argue for is not just looking at improving entry-level training and ongoing training standards for nursing assistants, but thinking about what are the core competencies that are required to provide high quality direct care across settings. Because a lot of that work, those core competencies are the same. This is the same type of care. But there's such divergence in the types of training that different direct care workers receive, and a lot of inconsistency around training requirements, training standards, and training delivery systems. So let's think about more consistency so that we are building a direct care workforce that is fully prepared and flexible enough to provide care across the continuum of care. The second thing that I wanted to raise was that supervision was clearly described as a driver of turnover or conversely of retention for nursing assistants in nursing homes. But supervision wasn't actually explicitly reflected in the recommendations as far as I could see. So I would like to lift it up, the need for identifying the core competencies of frontline supervisors who are often promoted into their roles without training and support themselves, so that we can build stronger, more competent supervisors to support frontline staff. I also want to suggest that we need a national campaign to change the narrative on nursing home care and nursing home jobs. So we need all of the systemic changes that are reflected in the recommendations, but we also need to change the narrative. We have to get to a point where we stop saying that no one wants to live in a nursing home. No one wants to work in a nursing home. That is not entirely true, and it generates a sense of hopelessness about the situation or powerlessness. So I think we need to change the way that we talk about nursing home care and nursing home work to reflect in our words our vision of what nursing homes are and can be. And then I just would make a plug for ongoing research to really elucidate the connections between investing in the nursing home workforce and reaping the rewards in terms of care quality and care outcomes. The next slide just shows some reports that PHI has released that sort of actualize some of the comments that I've made, which I would invite you to let me know if you would like to learn more. I'm happy to share the links. Thank you so much.
Thank you so much, Dr. Scales, for offering your remarks and offering recommendations as well. Our next panelist is Ms. Gil Sheridan. Ms. Sheridan, RN, is an Executive Vice President with LifeSpark Senior Living. She's an experienced nurse specializing in geriatric nursing for over 35 years. She serves both skilled facilities and assisted living communities in 2 states. Ms. Sheridan is a risk management advisor, clinical quality improvement advisor, HR advisor, and a culture thought leadership executive advisor. She assists with regulatory compliance as well as other leadership duties. Ms. Sheridan is actively involved in Care Providers of Minnesota, serving on the board of directors, Regulatory Forum, Assisted Living Committee, Chair of the Quality Committee, and is past Chair of the Board of Directors and past Trustee of the Care Providers Foundation. In addition, she's actively involved in the American Healthcare Association, AHCA, and the National Center for Assisted Living, NCAL. Ms. Sheridan currently serves as the NCAL Board of Directors, NCAL Quality Committee, Survey Regulatory Committee, and served as a past chair for the Workforce Committee, and now as a Workforce Committee member for AHCA and NCAL. She has presented nationally for AHCA and NCAL, Care Providers of Minnesota, Wisconsin Healthcare Association, South Dakota Healthcare Association, and Texas Healthcare Association.
Gail, you're on mute.
Sorry about that. Thank you for the introduction. I did want to just tag on to what Kezia was saying regarding the workforce and the national conversation around nursing homes and workers. Absolutely spot on. I continue to refer to our work as those who work in our profession. I know that everybody calls it an industry, but we are certainly in the profession of caring for people. And so I do applaud that. I wanted to speak briefly on what are employers doing? What are we doing to retain? What are we doing to recruit? And what are we doing with and for our employees? All of us participate in compensation surveys routinely and through associations. So it's not just our own buildings, but certainly the state and within regions. And we look at not only the hourly wages, we look at the whole compensation package, health benefits, all of that. And it was said earlier, this is very, very hard work. It is physically hard. It is mentally draining. And unfortunately, health insurance for females in this kind of work is very high. And so that's an area that we continue to work on. One of the things that we have done is really looked at those new employees that have chosen to come and work for us. And it's important for our leadership to really meet and get to know them and we call it the 730 60-day program, where we're going to ask kind of the same questions. How are you doing? How is your training going? Are you making friendships? How are you getting along with your supervisor? Which really speaks to that direct supervisor that oftentimes is promoted from within. And we have learned immensely from that. We learned that we needed to redo our orientation a few years ago, that it was not as effective as we thought it was. And it certainly was laborious. And so we really revamped after getting all this wonderful, rich feedback from new employees. And we learned other things. And so we have responded to those. And we continue to utilize that program, digging a little bit deeper, not just in orientation programs, but about our own culture within that particular community. We, as many employers, offer career paths. We pride ourselves, and frankly, a lot of our survival is on those individuals that we invest in, and we promote, and we help them, and we look forward to them continuing their education and staying with us. And so we do have scholarship programs. We do have tuition reimbursement programs. I'm happy to say we have 4 students, employees that have worked with us for years, that graduate nursing school in May. Our job now is to help them find a location, hopefully within our organization, to really pick up and further that nursing career that we've helped them develop. And we are not the only employer that does that, but it is a investment in time, investment in money, an investment in that particular employee that wants to serve and wants more education, and certainly has earned it through their work with us. I think one thing that we've all become better at as leaders through this COVID process, this COVID learning, is we are better at communicating. And although I will maintain, I think we were pretty good before COVID, we're pretty dang proficient. Doesn't mean we're where we need to be, but I think all employers have really focused on new ways to communicate and to keep employees close and those caregivers close. And I think also through COVID, many of our leaders, our administrators, our executive directors, many of those supervisors, they all worked the floor. They all worked other shifts. And although they've done it before, it became pretty routine. And so to be able to really work and lead beside their employees has been very, very good, with a deeper understanding and many, many quotes from them. This is very, very hard work. As of September of 21, there were 23,000 caregiver positions in Minnesota that remained unfilled. And we had a shortage of caregivers before the pandemic. Earlier in 2021, as the workforce was becoming even more exasperated than it was previously, we were asked nationally, how are we doing with COVID? And many of us said, okay, we can manage COVID. We got that. Our new pandemic crisis is our workforce. And that is what so much focus has been on. Not that the pandemic is over, but we now have tools that available to us that we didn't have in 2020. I think with that said, we do a lot of legislative work, and we are communicating with our staff and with our leaders what is happening and where our legislative bills are. So in Minnesota, you bet we're all for increased staffing. And nationally, the conversation, we're certainly in support of 24-hour-a-day RNs. But being in support of it, we are totally dependent on state and federal funding. Total. In Minnesota, we are what's called an equalized rate. So everybody pays the same rate depending on what their care needs are. But without state and federal funding to support that 24-hour RN and all of the staffing that would absolutely enhance quality of care and be so helpful to our staff and our caregivers, we can't do it without funding. I mean, we are totally dependent on that state and federal. So we support that, and we certainly would support the increase as long as there is funding to go with it. I will also say that regarding the workforce, nationally, the conversation, you know, from those of us in long-term care, we certainly put forth increased staffing, 24-hour RN, all of that back in 21. But it also included funding. So with that said, I think there's many leaders that are working legislatively and working with families, and families get it. I would suggest most of the thank you notes that we get, they consistently name caregivers. I mean, I got a thank you note for allowing our staff to attend the funeral of her father. And for us, it was a no-brainer, of course. So I think there's lots of things we are doing, and I think there's more that all of us can do regarding workforce and taking care of our caregivers. Thank you.
Thank you so much, Ms. Sheridan, for your remarks. Now we'll move on to our final panelist. Our final panelist is Ms. Sheila M. Harris. Ms. Harris is a trainer of trainers. She holds a Master of Science in Human Resources, a Bachelor of Science in Education, Associate's degree in Project Management, and a certificate in counseling. She's currently a registered nursing assistant and trained medication aide and works in a senior living facility in Edina, Minnesota. Her goals and aspirations are to study for a master's in nursing, and her interests include reading, doing research, traveling, and doing charity work.
Thank you very much. I'm so excited to be here in the panel, and this is a wonderful day. I would start by saying this. Anyone who loses the ability to do daily activities for themselves, they can no longer brush their teeth, they will not walk, they will not feed themselves, they will not go to the bathroom the way you and me does it without thinking twice. They will not reposition themselves in bed the way you and me does it without thinking. It's very hard. It's very hard. These are the kind of clients we meet in our day-to-day jobs. And they depend on someone to do everything. You will find them, some of them in assisted living, some of them in nursing homes, and some of them will even be living in TCUs for some time as they transit to nursing homes. So these are basically clients that are very fragile. They are customers that are different. The way we treat customers in different sectors would be very different because these are unique people. Can you imagine yourself losing all that and having to depend on someone to do that? You don't imagine because you feel it's for someone old. You feel it's not for you. But pause and think, should I lose all those abilities? What would I want? You would want someone to give you cares with all their hearts. You want someone to give you cares with experience. You want someone to give you cares with dedication. And worse still is if you lose all the abilities, but you're still cognitive, so you can think, you can see, you can reason, and you clearly see you're not getting the best that you should get, but you can't do it for yourself. So that really motivates me to doing the best, because I'm like, if I were the one needing those cares, what would I want for myself? I would want the best. So as a CNA, you cannot give the best if you don't have proper training. The training that they give when you start for 72 to 100 hours is very good, but retraining is key. Most of our clients, their conditions keep changing. At one point, they were in a different situation, and in the few days again, maybe they go into hospice. and that is a new situation. Do we retrain these people who are giving cares, or we just continue as if nothing has happened? This is a new situation for these clients. So they are facing different challenges now. Maybe they are weaker. They need more help. They are going into desperation. They know they are dying. So how much training do we give to these CNAs who are now taking care of these people? Or when we are doing the schedules, do we even think, or we just want to fill the positions? You just want to see someone there, but do you pause to think if they are capable, are they equipped to now take care of the current situation? In some cultures, there are some taboos and all these that are associated with a dying person. Do we ever pause to even see if we are incorporating some of these cultural issues into the way we are doing some of the things we are doing? Kezia was giving statistics, if I'm not wrong, about many of the direct care workers having been immigrants, and some being people of color, and all those disparities, they really speak into the way these cares should be given and planned. And as we do all this, are we giving the best to this person who used to live a full life? They had a home, they had a full life driving their car, they had a career like you and me, and now they're here, they can't do anything. Do we give them cares that we would like given to us? That's a big question. So customer service to me is very key in the way we do our activities in these nursing homes. These are our customers. They are unique customers. They are very senior members of society. They were parents. Some of them were working in different places. They contributed to society. As they choose our nursing homes as their last home, as they choose the assisted living where you work as their last home, are they getting the best they should get in their last home? Do we just take it as a job to do, or do we want to make sure they're happy? If we want to make them happy as we do this job, then it requires more than just wearing a blue scrubs, yellow scrubs, or pink scrubs and showing up to work. It requires commitment. It requires a recruitment strategy that will keep people there. The agency factor is becoming the norm right now. And the reason the agency is becoming very, very lucrative is they are able to pay more. And because of being able to pay more, we are having a challenge of direct care workers moving around looking for the extra pay. It could be a few dollars, but it makes an impact. If we could have this extra pay where we are, we don't need to move around. I've been questioning, I'm not saying agency is bad, but I've been questioning me moving into a facility. I don't know the residents, and I'm given a brief within 1 hour and you are expected to start working with those residents. I'm not saying it's bad, but I'm saying, is that enough for you to know which residents you're going to be working with on that particular day? How easy is your job going to be on this day? It's your first day in this facility, first day with these residents, and you're expected to do a good job within 8 hours and make the extra dollars and go to the next place. I'm not trying to critique that, and I'm not saying it's bad, but it's something I would not do because I don't understand how it would work. But the agency factor is becoming the way of staffing in different facilities, and it's because of the popular working short. And the working short is because of the not being able to retain anyone in one place. And how are we supposed to do a retention strategy? What can we do to make sure I stay in my facility maybe for 2 years. When I came in into this job, did someone spend time with me to ask me, what is your expectations as an employee? What is your expectations in the next 2 or 3 years? What are your plans? Do you plan to stay with us, or you are just planning to leave? So when we do such interviews, we can tell who we are bringing on board and what the expectations are. We can try to meet the expectations so that they stay with us. Some of these people we take care of, they are very friendly, especially when they see you all the time. You learn how to take care of them. They learn your ways, they learn your voice, and sometimes they feel so relieved just to see the people they see every day. Remember, some of them have even lost speech, so they cannot speak like you and me. So that retention strategy is the key. How do we make sure the people we are hiring are staying with us? It may not be 100% possible to keep everyone, but sometimes there are some things we can do, some flexibility here and there, and to make sure people stay so that we give quality to our residents. As someone says they're leaving the organization, do you just say bye, or do you have a word with them to ask them, why are you leaving? We would like to know why you are leaving. I mean, an exit interview. We may not stop you from leaving, but we want to know why you are leaving. Is it something we could do better to keep you around? And that would really go a long way in making sure that at least some people who stay longer to give best services would stay. One speaker said the job is physically and emotionally demanding. That is true, but the job is also very rewarding, especially when you know someone has put you in a position to do for them what they would normally do by themselves, but they're not able to do it. So the job can be very rewarding if we do the right thing. Still on the bad management and supervision, I believe most people like to leave their jobs because of unresolved issues. Do we have conflict and resolution management plans in place, and do we use them? When issues are unresolved, many people feel like they were not listened to. And that's when you'll find employees saying, oh, I need to go on call. When they say they need to go on call, they just want to go work in the next place because they feel like they were not listened to. So I still believe that listening, it may not be easy, but listening will really help to reduce the turnover of employees from one place to another, and trying to give that extra coin that everyone is looking around in different facilities so that nobody is moving around looking for it. I even have friends who quit their jobs and then they came back to work from the agency. So that really tells you they were not leaving the place because they didn't like it. They just wanted to come back and make more. And honestly speaking, everybody wants that extra coin to help them get along. And the long hours, no one can be productive after working for 16 hours and moving to the next job and working for 8 hours. No one can be productive when you work that way. Everybody needs to recharge. And that's what is happening, because if you have a family, you need a roof over your head, and you're there getting $14 to $16. And what can you do? You do 16 hours in point A, and then you punch out, and you go to point B, and you do 8 hours. By the following morning, when you come back to point A, you cannot be productive.
Wow, Ms. Harris, thank you so much. That's quite a lot. Your remarks are very heartfelt. I'm sorry that I'm cutting you off. But
Thank you so much. I didn't realize. Thank you.
Yeah, we have a lot of questions in the Q&A, so I wanted to make sure that our panelists have a chance to get some of their questions answered. But thank you so much for your heartfelt
You're
remarks.
welcome. Mhm.
Thank you again to our wonderful panelists for the wonderful, important information that you've provided. The questions are already coming in, so we'll move right into them. So the first question we have is, to our panelists, if you had to choose one policy priority regarding the workforce, what would it be? So maybe we can start with Dr. Mueller and then see what other panelists want to chime in.
Yeah, the priority for me is compensation for the nursing home workers. And without question, nursing assistants, the top of the list. But I'm just going to comment a little bit on registered nurses, partly because I'm in a school of nursing preparing people to be registered nurses. You know, it's like an uphill battle to encourage our nursing students to consider geriatrics as their specialty, let alone nursing homes as a place of employment. And when you do have a couple students who say, you know, I really like that, I'd like to work in a nursing home, and then they discover that they're going to make significantly less than if they had worked in a hospital, it's really hard to get nurses, registered nurses, into nursing homes. And if we don't address compensation, it will always have this problem. And Gail, I absolutely agree with you, you know, more staffing, all that stuff, we need funding. That's why I keep saying you've got to look at this report as a whole, because goals 4 and 5 address financing long-term care.
Thank you so much, Dr. Mueller. I see you mentioned Gail in the response. So Gail, what would be your top priority?
Well, for the audience, we didn't know what each other was going to select. So I am right in sync with Dr. Mueller. It is compensation. We need that state and federal funding in order to propel a quality agenda forward, and in order to, you know, build that pipeline, if you will, to prepare people. And I would just tag on one other thought that we have certainly hired nurses from hospitals to work in our long-term care facilities. And a lot of them go back to the hospital. Wages is certainly a part of it, but overwhelmingly, it's hard nursing. It's a difficult job. And with all of the regulations and everything that has to be done, that really, in many of our minds, doesn't really contribute to the outcomes of the care. So, you know, changing that archaic regulatory system to something that is reflective of outcomes of care and working with providers is always welcome. But definitely that compensation and to build over the next few years that pipeline for staff would be very, very welcomed.
Thank you so much. So maybe let's, as somebody who studies this workforce, Kezia, what would be your top priority?
Thank you. I actually have to echo the previous two responses. That's what I was prepared to say as well, because this work, I really want to uplift what Sheila said, that this is incredibly rewarding, important work, but we need to stop relying on people's altruism and their personal commitment to the work without also compensating them accordingly, because people have to pay their bills as well. And the one thing that I would add, thinking about nursing assistants, is what I would love to see is some federal leadership around raising the wage floor for nursing assistants and other direct care workers in the context of public financing that really sort of structures this continuum of care, because we need to grapple with issues like the use of contract staff. We need to grapple with issues like benefit cliffs that is a challenge experienced by nursing assistants and other direct care workers, many of whom rely on public assistance to make ends meet. If wages go up incrementally, there's a risk of loss of benefits that ends up being really financially impactful for workers and their families. So thinking about the full range of issues that go into creating a living and competitive wage for these workers, and also what needs to go into the rate setting equation and other considerations on the public financing front to really enable providers to reach those wage, to reach that living and competitive wage. So we really just need a lot more guidance about how to get there.
Thank you so much. This is a really interesting question that I think maybe I can pose to Jasmine and Sheila. So I know, Sheila, you talked a little bit about this in your remarks. So we'll start with you and then maybe toss it to Jasmine after. What do you think are immediate actionable steps that should be taken to improve recruitment and retention of nursing assistants? And in the interest of time, sorry, I'm gonna ask that you all, can respond as fast as you can so that we can move on to other questions. Thank you.
Okay, the immediate action that I think should take place is make sure the pay or the wage is raised up. And the other thing is to make sure we are doing exit interviews so we know why people are leaving and where are they going to, so we can mitigate. Yeah.
Thank you, Jasmine.
I would say also, in addition to what others have shared, is kind of understanding what are the barriers, and like Sheila has talked about as well, for people actually being in that environment. So it's one thing to recruit, but if we're not retaining people and if the environment is not conducive to individuals that are working there, then that would just be a lost cause. So really understanding and changing, transforming that environment is important. So the systemic barriers to retaining the workforce.
Thank you so much for the succinct answers. Let's see what other question. This is a nice one too. I'll post to the entire team, and anybody who wants to take it can take it. A possible unintended result of limiting the NASM report to nursing homes is that care for older Americans may be driven into assisted livings and home and community-based service REMS and are under state and local control, making it even harder to compare quality of care and quality of life for vulnerable older and disabled persons. What are your thoughts about how the report can truly result in improved outcomes when maybe older and disabled adults are cared for in assisted living facilities? And I'll throw that to anyone.
Kezia, I know you talked about your general focus on other settings too, and Chris, I see unmuted you.
Well, I was just going to say it's a really big question, so I was trying to sort it out. The report very specifically focused on nursing homes with the acknowledgement that that there's a continuum of long-term care. So that's all I can say at this point.
I feel like
I would,
yeah, go.
Yeah, I had to get my unmute button. I don't know that people are driven to assisted living. I think that they choose assisted living, and there are many levels. Assisted living became licensed. So we all went through licensure back in 2021. And so the education for that director, if you will, is certainly there, and the training requirements, and the number of regulatory visits and surveys. So all of that has really, we've had regulations, but it's even more intense now. But people do choose to go to assisted living. In some cases, it's more affordable. Certainly the apartments and the privacy, and it is, they can still receive home health care. And, but they are definitely regulated by the state of Minnesota. And data is collected and information is submitted. And so we feel really good about that. We're not against regulation. But we are certainly in support of regulation that supports positive outcomes, and maybe not so much on busy paperwork that just crosses the T.
Thank you so much, Gil. I think maybe our team will get together with the panelists and respond to the rest of the questions and then send the responses out to the attendees. But I just wanted to thank everyone and hand it over to Dr. Shippey for her closing remarks.
Thank you so much, Dr. Kimbang, and everybody, the panelists, and all of you who joined us today. I hope you appreciated the rich conversation we've had today. The recording of this session will be posted on our website and also shared with those of you who registered. We'll also try to send answers to the questions that were not answered. And I would just say it is clear that workforce is a key metric of quality of care and long-term care, and it will really take all of us to ensure that we can improve workforce quality going forward. Thank you all so much again, and take care.